Today, she will be speaking on the topic of physician and patient engagements in healthcare. A very relevant topic in Indian circumstances too, apart from the United States of America, and a topic of my own interest also. Now I request her to come and deliver a talk on this subject. Thank you.
I want to thank all of you, specifically our chairman, Shri Chawla, who is not present amongst us, but I'd like to extend my thanks to him for inviting me here. The Pro-Chancellor, Dr. Dogra, Vice Chancellor, Dr. Shyam Singla, Pro-VC, Dr. Dalip Singh, the Registrar, Mr. Prem Singh, the Director of Health Sciences, Dr. Kohli, and the Dean Medical Faculty, Dr. Nagar, and all the other present deans, directors, HODs. I am very happy to be here, and thank you for allowing me this opportunity again. I'm going to speak to you today about a topic that's very close to my heart, patient engagement. I started off with thinking of this topic as a physician engagement, and then I realized it's not possible to have patient engagement and physician engagement as two separate things, because the physician is not engaged with the patient. There is no way the patient would want to come to an institution or be aligned as a customer. At the outset, I'd also like to say we are really healthcare industry is actually a service industry, and a lot of books, articles will compare it to not something that is something of the nature of service as dan or service as donation, but service as a hotel industry, because there is a process involved. There is a customer at the end of it, and you want the customer to come back to you. And most of the healthcare models in US are based on looking at a patient as a customer, and that's how we approach patients. And there is definitely a misalignment in how we view things in America as patient being a customer and how a patient is viewed here in India. So I'll try to draw on those parallels in this short presentation I have for you. So starting off with patient engagement. Realistically, most of the countries in the developing world, including China and India, are dealing with what they call the iron triangle. So all the care that's provided is actually a confluence of patient access, operational efficiency, and high quality of care that's delivered. But the reason it becomes relevant and why they call it an iron triangle is if you pull at it from one side, the other aspects of the care will get affected. Because no institution, whether it's in US or in India, can provide everything together at the same time. If you provide adequate patient access, your operational efficiency will go down. If you increase the operational efficiency, somewhere or the other, you're compromising on the quality of care. So this is a very difficult balance we have to maintain in healthcare to provide good care. And the patient is mostly our issue, at least from what I understand at HGT, is patient access becomes very relevant. You want more and more patients to come here and come back again. So focusing just on operational efficiency or high quality of teaching is not adequate, because you have to keep getting these patients to come back to you, and hence there is increase in business. So if you look at the current market structure and in the Indian situation, in the Indian healthcare market itself, you have the government financed healthcare facilities and you have the private specialty healthcare facilities. But the gap in care, which is what I consider an opportunity for institutions like SGT that are positioned way out where there are villages and there are less of a healthcare facility availability, is that this particular gap can be bridged by institutions like SGT. I actually saw SGT as an opportunity rather than a situation which is in the market that is logged by All India Institute from one side and the city hospital on the other. I actually see it as a place that can fill this very interesting gap in care because of the access to the nearby villages. It just requires a different kind of approach. And this is, if I say anything here that seems uneducated because I didn't understand the situation about SGT properly. Please forgive me and do correct me. I'd like this to be somewhat interactive if possible. So patient access, what to do with, what do patients really value? For patient access, most of patients are looking for is convenience and what they perceive as quality. I don't say quality as in Mayo Clinic or Sloan Kettering. I say what they perceive as quality care. Patient perception of what is being done for them is much more important than what is actually being done for them. You could actually be doing the best possible thing for them, but the way a person spoke to the patient or the way the patient felt when he was interacting with the physician actually can totally ruin the whole engagement process with the patient. So looking at those two, and I'd like to go further, when it comes to convenience, I'm going to take this apart a little bit for you. Physician access, availability of the physician. How is the physician available? Can they approach? So in the US, we have started giving patients access to emails. There is a website that's available. They can call in if they have questions. They can ask those questions via email or via a general sort of an email system that we have, which will clean out the emails and direct them to different physicians so they can actually interact with the patients directly. We take calls from the patients at any time. In the middle of the day, they will call us, and that's how we are geared to operate them. And they love it. They really like the fact that if they want to talk to me today about a lab finding that I generated for them, they should be able to call me and find out, what does this sentence on your report really mean? And that makes them want to come back, because then the next time they say, you know what, I would like that report to be read by Dr. Sharma again, because she was very nice to me last time, and they remember that. Connectivity is what I just touched upon. Also connectivity via mobile phones. Everybody has mobile phones, and we provide access of those kind of text messaging, reminding the patients. In fact, I'm not sure, at least on a daily basis, I would get one message from the hospital system regarding one of my children or myself for an upcoming appointment, reminding them that they should come up. And that's one way of pulling them in, because sometimes they themselves will forget, but when you call them, they will come back. Continuity of care, maintaining volumes of their data. So when they come back, you can look it up again. That adds to the personalization. They feel like this doctor remembered me from the last time. That personal touch, Mr. Thomas, Mr. So-and-so, I remember you were having this issue last time. That little note that you keep in the corner of your drawer about Mr. Thomas is the reason Mr. Thomas will keep coming back to you, because you remembered he had 2 children and one of them had asthma. That makes a lot of difference to these people. Follow-up. So in US, we do call the patient, follow up to find out how their experience was in the hospital yesterday. We noticed you came. Did you like the physician? Was the physician nice to you? Was the allied staff nice? Was the room clean? Were you provided information that you needed? Each of those things will make the patients keep coming back to you because they feel that they are taken care of. I'll come back to perceived quality, and I'm referring to this book called If Disney Ran Your Hospital. I wonder how many of you have heard of Orlando, been to Orlando, to the Disney World. If you remember going there, you will realize that the moment you walk in, everybody will smile at you. No matter whether you are upset, whether you're mad, whether your kid is weeping, they will approach you and they'll say, welcome to the Disney World. And there will be the biggest smiles possible on everybody's face. They could be closing the doors behind and screaming at each other because they are frustrated and the workload was too high. But the moment they close the door and they come out, in front of you, they are the best. You dropped a handkerchief, they will pick it for you. If there is a tissue you drop by mistake, nobody is looking, they'll pick it up, they'll put it away. You love Disney, everybody loves Disney, but the reason is if hospitals were run according to Disney, and that doesn't mean money, that means the smile. Disney is the epitome of customer service. When somebody walks in and you smile and say, Harish ji, आज कल रात को सोए कि नहीं सोए ठीक से सब ठीक ठाक है घर में. it makes a huge difference to the patient feeling, yes, this person is my friend, and they will open up, and they will come back. So with that in mind, and keeping STT in mind, I thought of a few things that could be potential ideas of what STT could do to improve the flow of patients. Now, understanding the market structure here is not so hard because you have AIMS that's coming up with some multi-million-dollar project to run a new cancer care center very close by. Right next door is a city hospital, which is pretty huge. I drove by it. They have quite a few facilities, and it looks like they have a lot of stuff that would attract a patient to go there. So what could STT do to establish itself? Again, I come back to gaps and how gaps equal opportunities in a market situation. We all know elder care is a huge issue. Most of our diseases happen post 65. That's when people suddenly become aware that they have health issues. Before that, we have the idea of the Young Invincibles. We call them the Young Invincibles. You think nothing can happen to you. And the time you realize something can happen, it's usually by 60, 65, and that's the elder care. If you fill in the gap of elder care and have some sort of an old age home or facility for elder people to hang out, socialize, that would draw a big group of people that you could provide services on premises. And it's just thinking about something a little differently than just looking at it as a hospital structure. They will not come for the healthcare, they will come for their social aspect and the bingo games or anything else you organize for them that they can get together for. But that's where you get that patient population and your geriatrics facility can take off. Post-operative and recovery units. With AIMS coming up, there will be cancer care, there will be chemotherapy, there would be radiation. These patients with post-care issues may not be able to go back home and be able to be handled by their family with infection and other complications. Post-operative and recovery units can actually help you draw these patients and also provide you that information about the structure of actually oncologic care, and that would be another exposure to the students and the fellows here. Childcare, early education is the best way to attract pediatric population. You just provide a little early care facility where patients come in, younger patients, and that could be a spot for pediatrics to intervene. So it's just a matter of looking at the same situation in a little different way, and that would make a whole lot of difference. There are NGOs that are aligning with a lot of hospitals to reach out into the communities. They would actually go with the junior fellows and residents into the community and talk to the patients and draw them in. So that's one other way of doing this. And then there are, of course, the interdisciplinary models, and I brought that in because I thought you have a great management staff here. You also have a little course for healthcare administration, drawing those people in and making them do little projects in the medical operational arena would be such a great idea, because those graduates can actually give you all the information you need about things that can be done operationally. And it would be a great project for them, and would also help the medical group. Now, getting back from patient engagement to physician engagement, and I'll try to be quick because I think we are short on time today. All this is for patients, but it requires physicians to feel as engaged in what's going on, because if the physicians feel they are not respected and that it is not something they want to do, all this is useless. And there are best practices that we talk about all the time, and it seems very idealistic. But at the end of the day, we all have to agree that when a patient walks in, the care the patient gets should be quality care, should be safe for the patients, the outcomes should be acceptable by standards, and patients should leave satisfied. I mean, these are very basic things that I'm telling, that I'm sure everybody knows, but very hard to put in practice if the feeling is not that this patient is a customer. So the way to deal with that is, and that is something I feel when I come here, I feel there is a big difference between how physicians approach their work in this country as opposed to how the physicians approach their work in America. And it got me thinking about why the same person, which is me, in India behaves differently than when I go to America and I behave differently. And I'm the same physician that was educated right here. And I feel it's got a lot to do with what do you give the physicians as incentives, and what are they getting? If a flat salary is all somebody wants, then that's how it should be. But if you incentivize them for patient satisfaction, which is what we do there, we are incentivized. I will get a small bonus if a patient writes a little note for me and says, my experience with Dr. Sharma was fantastic. And those little notes add up at the end of the year. So if you really look at the whole structure, aligning pay to performance, and the performance that aligns to the overall strategy of the institution is what really gets this whole boat going. And the other thing is having role models within the group that people follow. There's a person who's really good. I want to emulate this person. Maybe that person makes more money, and maybe I want to make more money like this person because he's good, so maybe this is how I need to be to make more money. But whatever it gets going, it needs to be aligned with what the physician expectations are, and only then can they deliver what you want them to deliver in terms of patient satisfaction and engagement. And on that note, I would like to open this little presentation of mine to your questions. Thank you.
How to inculcate this idea of being a customer? Like we go to a bank or we go there, they tell you, how can I help you? But here we see lot of people, and I mean how to entertain them as a customer. We think they are a liability on us. They have come, we have to see them and pay them and do this thing. But how to inculcate this idea that they should be treated as customer? Like it is a big question for a country like us.
The blunt one is, if I'm told that if this patient leaves happy, I will make money, I will work. That's the blunt answer. The sweet answer is, and that is not untrue, the sweet answer, I'm not making it up, but it's a fact. I showed you the iron triangle in the middle. To make a customer happy, you have to have the operational structure and the support. And if those are not there, no matter what you do, will not make it completely. However, again, I'll go back to the Disney model. A smile will make a whole lot thing go better. And it seems like I'm giving you some sort of a pep talk here, but it's really not. The worst day can get better, and the worst patient experience can get better if you put a hand on their shoulder, which is what we do, and we are taught to do, and say, no, I understand what you're going through, and everything calms down. And a lot of the stuff can be made up because the physician is the face of the interaction with the patient for the entire institution. So although the institution backs up the physician's perception of the institution is only from that interaction. And that's where the responsibility comes in, big time. And we are taught that, we are made to do that. If we don't do it in USA, there is a consequence to it, because there is money involved across the board. And yes, it's a fact, but that's my only answer to your question.